have the distinguished Dr. D. Ramamurthy sir, who will be talking about all about Torics, the Gateway Premium IOL. It's a topic many of us deal with, yet often wish to master even more. So, sir, I request you to kindly come up.
Thanks a lot, Shri, Supriya, and the team for this, Savio and the team for this wonderful opportunity. Always enjoying getting associated with you all. And thanks for Hoya for putting this together. The topic given to me is all about Torics, the Gateway Premium Intraocular Lens. And I think we did discuss this in the previous session also. I've just divided this into a dozen different tips that we routinely follow when we implant toric intraocular lenses. The tip one is do not use refractive astigmatism. We all know that there is a concept of lenticular astigmatism. Refraction may under or overestimate true keratometric astigmatism. So just because the patient does not have cylinders in these glasses does not mean they do not require. You don't require an eye trace to take up toric intraocular lenses, but just to show you this particular situation where the pointer is not showing up, where you see that this entire astigmatism is internal, while what you see that, and this is a total astigmatism. Which one here? This entire astigmatism is internal, and this is a total astigmatism. The cornea itself is pristine. So, sorry about that. So even though the patient had about a 1.5 diopters of cylinder right through in the spectacles, he is not a candidate who requires glasses simply because this internal astigmatism is going to go away completely, and the cornea itself is pristine. So the astigmatism that is there in the cornea is just very small, and toric intraocular lens is not needed. Contrast it with this situation where the corneal astigmatism and the internal astigmatism almost tend to neutralize each other, so that the patient may not have been wearing glasses right through their life, but essentially the astigmatism in the cornea is almost 1.18 diopters. So obviously this candidate would benefit from toric intraocular lenses. So do guided by the astigmatism in the spectacles, but that's not what you determines that whether the patient needs torics or not, is essentially the anterior corneal astigmatism. Use the right instrument and the formula. Basically, almost our entire, across the spectrum of our hospitals, we use the Barrett-Suter formula for all the different calculations. And go-to formula for us, even for every case, is a Barrett toric calculator, not the Barrett Universal 2 formula. Obviously, the various other iterations helps you in different situations. Why is it that we swear by the Barrett toric calculator or the Barrett-Suter formula is that it incorporates the posterior corneal astigmatism, which is most often against the rule astigmatism. There is a drift of astigmatism over the age of over the life of the patient, about 0.3 diopters for every decade of life. This is factored in this formula. It targets about 0.25 to 0.5 diopters with the rule astigmatism, which is again a benefit because the shift that occurs over the lifetime of the patient takes into consideration the IOL axial length and the IOL power. There is something called the toricity ratio. The amount of toricity that is needed in a plus 30 diopter lens and a plus 5 diopter lens is totally different. And that is again, there's something taken into consideration. When the other formula talk about the thickness of the lens, it is essentially the thickness of the natural lens that is there. This is one formula which takes into consideration the thickness of the intraocular lens that you are placing, which essentially determines the principal plane of the lens, which would vary depending upon whether the lens is meniscus or plano-convex or biconvex, and that variation will occur depending on the intraocular lens power that you are placing. You can introduce the centroid value of the induced astigmatism. I'll briefly delve upon that. The K index might again be variable, and that can be incorporated in this. Where exactly is this formula available? Most of the modern optical biometers do have this, and I do believe that if you had to invest between upgrading from a mid-level phaco machine to a higher level phaco machine, or go ahead and buy one of these optical biometers, is better to invest in an optical biometer, because getting the biometry accurate is extremely important. I'm sure you all as proficient cataract surgeons can do a reasonably good phaco in all circumstances. Just in case you have not reached the level of practice, you can afford a optical biometry. You have these ASCRS and APSCRS uh, websites where in the front page itself you have the IOL formula and you can access this. And I believe that a well done autorefractometer and a immersion A scan can, in experienced hands, can give you values which are almost akin to we can get an optical biometer. So all these formula is available there. The tip 3 is to, as I said, my go-to formula is not Barrett Universal 2 but Barrett TK toric calculator. Oftentimes, as I mentioned in the morning also, we are asked what exactly is the astigmatism beyond which you go for a toric lens. But you can see here just about 0.6 diopters of astigmatism in this particular situation. But what is indicated is a T3 lens because it's against the rule astigmatism, which is potentiated by the against the rule astigmatism in the posterior cornea. But contrast this with this situation where you have 0.68 diopters at oblique astigmatism and this patient does not require a toric lens. So it's not just the magnitude of astigmatism which is important, but it's the axis of astigmatism which needs to be taken into consideration. So essentially what we do is to, once the patient requires a cataract surgery, even before the counselor meets the patient, the optical biometry is done, we decide whether the patient requires a toric lens or not. Then all the conversation about whether it's toric monofocal or toric trifocal or toric EDOF lens comes in, or whether it's a simple monofocal or a trifocal. Otherwise, if you counsel the patient for a trifocal just because the patient was not having significant astigmatism in the spectacles, later on you find this out, the conversation changes, and again you have to re-counsel these patients, which becomes a little painful. So always be guided by the astigmatism that the formula tells you. Tip 4 is with the rule and against the rule astigmatism entirely two different animals, and I think I have already alluded to this. As you can see over here, it's a against the rule astigmatism for just a 0.98 diopters. What you require is a T4 intraocular lens. I am once again driving home this point because don't go just by the magnitude of astigmatism. You see this situation, 0.75 diopters of with the rule astigmatism, the patient requires a non-toric. So essentially, it's important that you calculate the amount of astigmatism that needs to be corrected. Just in case you do not have the optical biometer, you can access it on the websites also. You can see here 0.75 diopters of astigmatism at 180 degrees, which is against the rule astigmatism. What's required is T3. Exactly the same amount of astigmatism, but with the rule astigmatism. Mind you, this is not on the optical biometer, it's at the website. What's indicated is a non-toric intraocular lens. So what's tip 5? Correct even low astigmatism with multifocals. I think this is a point that has to be repeated over and over again. This was way back in 2019 when the trifocals were just coming into the market. 0.87 diopters of astigmatism at 18 degrees. At that time, I was also not so focused on torics. I was very keen on putting in a trifocal, so went ahead and implanted thought the astigmatism quite low, went ahead and implanted a trifocal lens, and non-toric lens, and what you see over here is the patient had a certain amount of mixed astigmatism. Even though the near vision was reasonably good, the uncorrected distant vision was just 6/18. So obviously the patient was quite unhappy. But he was agreeable, and he said that let's wait for 3 months and then we'll do a laser touch-up. We usually offer a laser touch-up free of cost to any patient who has a suboptimal refractive outcome. But during the wait period, he went ahead and underwent surgery in the other eye, in which case you can see almost the same amount of astigmatism. But here what we implanted was a trifocal toric lens, and instead of just a plain trifocal, and the patient ended up with a very optimal result. You can see the left eye which ended up with a 6/6 uncorrected visual acuity. So actually the patient decided not to undergo the laser vision correction because bilaterally implanted he was quite comfortable with the quality of vision and the quantity of vision he had. So essentially whenever you are implanting one of these premium multifocals, trifocals, geometric lenses, etc., even small amounts of astigmatism need to be handled. That's the reason many of them have come up with the T2 models also. And another important aspect is that I used to consider that my 2.4 or 2.2 millimeter temporal clear corneal incision induces a astigmatism about 0.47 diopters. That was what I have calculated with my Hill RBF calculator, having implanted about 30 lenses of each different type. But today, we understand because of seminal work done by Doc Koch, Graham Barrett, etc., that the astigmatism induced by incisions does not only have a magnitude, it has a direction also. I'm not going to go into the details, but if you plot it in uh, on a double plot, then you find that very often the astigmatism induced tends to neutralize each other, so that a well-constructed temporal clear corneal incision, which is 2.4 millimeters or less, induces just about 0.1 diopters. That is the reason we no longer do incisions on axis, because it hardly compensates for any amount of astigmatism. In case there is a significant amount of astigmatism, we go ahead and do a temporal clear corneal incision and use a toric intraocular lens. So extremely important that you incorporate this in your calculation formula. Repeatable axis marking and both pre-op and intra-op. Basically, as you can see over here, all these things work well. Freehand marking, I thought it was very silly, but I visited David Chang, and all he does is a freehand marking for all his cases of toric intraocular lenses, and almost 80% of his cases are toric intraocular lenses. You can use a bubble marker. I'm not going to go into details how you use it. Before dilating, you can use a slit and then use this bisecting the pupil and have marks both at the 3 o'clock, 9 o'clock and 6 o'clock meridian. Of course, if you have access to a Callisto, as was happened today morning, or a Varion, which I more commonly use, then this significantly enhances. The more important point is that you standardize your technique. Don't do some technique in each case. Whatever works well for you in your hands, that's the technique you need to adapt. And once you have standardized that, then you find that your results are very optimal. We have the digital marking system only in a few of our centers, but almost in all our centers, more than 40% of the lenses are toric lenses. My other surgeons have mastered the act of implanting these lenses in the right axis by adapting to whatever technology that they are comfortable with. Again, intra-op alignment is extremely important. As you can see over here, once you have introduced the intraocular lens into the eye, viscoelastic removal has to be quite complete. In case it's not you are not doing a hydroimplantation, is not only in front of the lens but also behind the lens. You have to go ahead and implant the lens. Usually the final alignment takes place after you have removed the viscoelastic quite completely, so that only clockwise rotation of the lens that is necessary. And you can see that after removing the viscoelastic quite completely, this video is a little dated, because last couple of years I have almost completely switched over to doing my implants under saline. And if I am doing that, this is what I do. And as you can see, the irrigation cannula goes right inside, and though my entire phaco is done at the intraocular pressure of 30, I raise it up to 90 just to have just for this particular step, just to bloat up the anterior chamber, push the posterior capsule as posteriorly as possible. And with this acts as a guide. The intraocular lens slips in behind the irrigation cannula, and it also stabilizes the globe quite nicely, and you can implant the lens in the axis that you need precisely. And I think I'll skip the rest of the video. And what is tip 9? When do toric IOLs get misaligned? It's extremely important to understand that most often the misalignment of the toric lenses occurs in the first 1 hour after surgery. That is the reason that when you have haptics which are roughened up, or which the stickiness of the haptics to the optics is not there, they open up faster, and then they get abutted onto the capsule of Fornicis quickly, stabilizing these lenses. This is one of the reasons that we also, most of our surgery is done under topical anesthesia. We do not patch our eyes normally, but whenever it's a toric intraocular lens, nowadays 70% of my patients receive a toric intraocular lens. I always patch the eye for about the first 1 hour or so. Of course, it is not very scientific because the other eye is open, so some amount of movement can happen. But then It gives me certain amount of comfort. We do not want the chamber to be shallowing in the immediate post-operative period, and keep the eye patch, and just before discharge remove the patch and send the patients home. And if the lens has been stable for the first 1 hour, the chance of it rotating is not very much there. And irrespective of the amount of the basic intraocular lens power, rotation of these lenses does not occur. Frosted haptics, I think that's one major advantage of the Vivinex toric intraocular lens. As you can see over here, the roughened haptic surface, both anterior and posterior, and the textured haptic surface. Essentially, this creates a certain amount of friction, because of which the lens nicely abets onto the capsule of phonesis. The release of these lenses from the optic surface, Sri Ganesh also mentioned it during his live surgery, from the optic surface is much quicker, so that it unfolds much faster. And you can see that and you will see this was not demonstrated by any of us during the surgery, but as you can see over here, the haptics are roughened, and because of this, there is a certain amount of friction that is there between the, can I take a minute? Between the capsule of phonesis. You can see the roughened haptics, and you can place the in the capsule of phonesis. Once you place that, the lens tends to remain in place. And in case the lens has been in place right through this immediate in the first 1 hour, it's unlikely to rotate. Just in case you have residual astigmatism, our go-to formula is the Barrett RX formula, and which tells you whether what will work in this patient, whether it's IOL rotation, IOL exchange, or a piggyback lens. And the most important factor, this is a case where you have, this is the amount of residual astigmatism. You must understand that rotation of the intraocular lens is going to work only when the spherical equivalent of the residual astigmatism is almost zero. Like in this case, the -2, it's the residual, the spherical equivalent of the cylinder is 1 diopter, 1.5 diopter. It's a mixed astigmatism, because, and this is the rotation might help. Because when you are rotating the lenses, you are not introducing any power or taking any power, you are only redistributing a power. And these are the two formulas. You can either go ahead with the Alcon, these are the two formula that we normally use. The Barrett RX formula, the astigmatismfix.com. As you can see over here, in both these situations, shows you that the lens has to be rotated by about 33 degrees. Whenever the rotation is required, we usually wait for a period of about a couple of weeks. It's a good idea for the capsule to fuse down a little bit. Even though it's a hydrophobic acrylic lens, you can rotate these lenses. And all we do is to go in with the irrigation cannula. Don't introduce any viscoelastic. Just use the two side ports. Usually you can open up the primary side ports itself, which was created during the primary surgery, and you can rotate this lens into the right axis. Do not compromise on the results, especially if the residual astigmatism is the spherical equivalent is almost zero. Then rotation of these lenses always gives you better, more optimal results. Because of lack of time, I'll skip this just to understand that it's come to place. Just in case the IOL exchange may be needed, in case there's just a plain astigmatism or spherical error that's there, you can also have, I calculate the piggyback intraocular lens power that's needed. I'll skip this video. I think my final tips to maximize outcomes, multiple measurements of keratometry, especially if you're doing an auto-K technique. Consider, but do not be guided by refraction cylinder. It's essentially the anterior corneal astigmatism which matters. Check ocular surface, and the surgically induced astigmatism is just about 0.1. The posterior corneal astigmatism is to be considered by the formula, and pass the eye, the immediate post-op. At surgery, a little longer incision so that they close down very well. Avoid overinflating these incisions, because even if you remove the visco completely, if there's enough amount of fluid, these lenses can rotate. Ensure complete visco removal, and nudge the intraocular lens onto the PC so that there is certain amount of stickiness of the optics to the posterior capsule. Slightly smaller rexes so that there is good overlap of the rexes onto the optics. And ensure that sometimes just the removal of the speculum shallows the anterior chamber, and that can again cause slight rotation. And if residual astigmatism is there, rotate the lens in about 2 weeks. And you can use the Barrett RX formula or the astigmatismfix.com. Thank you so much for your kind attention.
Thank you, Dr. Ramamurthy, for those excellent pearls regarding toric IOL implantation. Just one question. Do you think that a CTR has any role in large bags and long axial lengths? Because there are some surgeons who, for myopic eyes, they routinely put in a CTR and then the toric IOL. So what is your take on that?
I don't do that, and I don't believe that it really helps. I showed that graph also where, irrespective of the spherical power of the intraocular lens that's implanted, the lens remains quite stable. So I don't think
I
it
also
serves any
don't
purpose.
put in CTRs. The other thing is many times immediate post-op you do an auto-ref. After a toric IOL you do an auto-ref and it's showing like 0.75 or 1 cylinder and you're worried. But you have to wait, okay? Don't do anything for a week or two because again your ocular surface has to settle down, your wound is hydrated, so your astigmatism, corneal astigmatism is going to change. I normally take a decision to rotate only after a couple of weeks because then the ocular surface has settled down, the wound hydration has settled down, and also the bag is a little more sticky, so when you rotate it stays in place.
I completely agree.
Just a small question. For all the people who are starting off toric IOLs, would you still insist that they calculate their SIs?
No, I think SAA you can either take it as 0 or just 0.1. There is a possibility of customizing your SAA because it's a centroid value. Even instead of 0.1 you get a 0.12 or a 0.08. It hardly makes a difference because lenses come in steps of 0.5 diopters. So it's a good idea to just keep your SAA as 0.1 and most often it will work well.
And for all the people who do not have the digital marking system, what's your experience about using the smartphone assisted apps?
Frankly, I have not used it much, but when we transitioned on to the digital marking system, we did use the bubble marker which we were using earlier, and we have even published on that on the digital marking system. We found that a well done bubble marking, it is as effective as a digital marking system. So you need not stay away from torics just because you do not have access to a digital marking system.
So in fact, before we got our digital marking system, we were using most of us have smartphones over here, and these apps which are available, there is one Tor Easy, there is Tor Axis, and there is one iToric by Dr. Saurabh Patwardhan. These use the accelerometer of your smartphone, and they give you very good results. And in fact, you can have a freehand marking and then use the app and then see what axis it is at. So all the fine adjustments can be done with this particular app.